Any further from me, I'd like to introduce Naz Campanella. She's the ABC's Disability Affairs reporter. She holds a communications degree at the University of Technology, Sydney, where she majored in journalism. She began her work with ABC as a cadet before working as a regional reporter for Triple J, as many of us know her voice from. Naz is totally blind, and she lives with a neurological condition that prevents her from reading Braille. She was the first blind newsreader in the world, and she's a great friend of my neighbour. So please join me in welcoming Naz to open.
Thank you, Gillian. And like you, I also feel quite strange doing a presentation. This is only the second one I've done in 12 months that has actually been in front of a live audience. So treat me kindly, and we'll see how we go. I want to start off by getting you to close your eyes. I want you to think back to your early childhood. What was it like? What are some of the memories that pop up when you think about those early days? Hopefully for many of you, it's smiles, hugs, laughter, sand between your toes, running barefoot on the driveway, whatever it might be. I'm sure it's memories of joy and happiness and lots of family time. I have those memories as well of my childhood, but the ones that really stick out are ones of mostly being in hospital. They're memories of feeling needles stinging into the crooks of my elbows, feeling numbing cream or struggling to get a cannula in the back of my hand, doctors talking about me, not to me, and my parents feeling increasingly frustrated by going to the same specialists or seeing the same nurses at the same facilities over and over again and being asked the same questions or being asked to repeat the entire history and what had happened to my vision. A lot of them are memories of feeling incredibly anxious and shaking uncontrollably before going into theatre and needing a warm space blanket to calm me down. So much so that I could never remember, or at least never had the ability to say my name or my birth date so that the nurses could check that I was the right patient and that I had the right wristband on. My dad always used to come in to theatre with me and stay until I fell asleep. That was one of the special memories. And for a long time, I wasn't able to go into theatre on my own. In fact, the first time I did was for a minor procedure last year at age 31. Sometimes even now, I'll smell certain things, Dettol, nail polish remover, and they'll remind me of hospital. And I'll instantly be transported back to that time, back to those traumatic situations where I didn't want to be there. There are also things like colour. And for someone who has no vision, maybe that's a little hard to understand, but I have this vivid memory of seeing white hospital walls and sheets. And I have no idea if it's the same white that you see, but for me, white is not a pleasant colour. So much so that when I got married 3 years ago, everyone just knew instantly that I wasn't going to walk down the aisle in a white dress. So I remember having these situations happen over and over again where I'd be held down and people would try and obviously convince me to have needles or to have surgeries. And I would plead with my parents and the doctors that I didn't want surgery. I didn't want countless procedures to try and fix my sight. At age 9, I bribed Mum for a Posh Spice Barbie doll so that I could have surgery. So that was the only way that I would allow her to let me do the surgery. At age 10, it was, Mum, I'll only have the surgery if you let me go to a fancy hair salon and dye my hair blonde. As I got older, it was things like a new pair of high heels, makeup, until my mid-teens, where I said, I'll only do this surgery if it's the final one. I wanted to be happy. I wanted to be a normal teenager. And I wanted to live my life blind. I wasn't interested in cures or being fixed. And I think that was something that was really hard for both the doctors and my parents to understand. Initially, when I had my diagnosis, which wasn't really a diagnosis, even today it's still known as a rare retinal abnormality, it was almost declared to my parents as something that would be negative, hard, challenging, this difficult life that would never, in a sense, be lived to its fullest. And that simply hasn't been the case. But at the time, it's what my parents were fed in terms of information, and I fed off that. And their frustrations with negative things that people said also fed to me. And so I started to feel as a kid like things needed to be fixed, or that I needed to find a cure. I felt like a guinea pig. I was often being flown to some weird and wonderful hospital across Australia where someone had come from overseas with a new technique or a new procedure that would be touted as something that would fix my vision. And it never worked, clearly, because I still have no vision. But it started to become just part of life that every now and again I was pulled out of school and I would miss out with learning, and I would miss out on time with my friends. And I wasn't living my best life because I was in and out of hospital trying to be fixed and cured. And so that day when I said to Mum, I'll only let you put me to sleep so we can do this last surgery if it's my final one, was a real moment for my parents. It was a moment of going, why are we doing this? She's really happy. She's okay. And it's time that we listen to her. And it was my mid-teens, and it was the first time anybody had listened to what I wanted in regards to my health. And for me, that last surgery, I came out of it and I felt for the first time utter relief, because I felt like it was the last time that I was going to have something done that was against my will, that wasn't discussed with me properly. Of course, I've had other surgeries since then, but there have been ones where they've been my choice. They've been discussed with me. Information has been given to me so that I could make my own decisions. And as I got older, I was able to advocate for myself and advocate for the sorts of accessibility that I needed in healthcare. That was things like explaining to doctors that you can't just show me a diagram. You need to actually take my hand and you need to show me, trace my hands around a diagram to show me what something looks like or what part of the body it's in and what you're going to be doing. You need to articulate in very simple language what you're going to be doing and how it's all going to work. I learnt along the way what I needed. And so whenever I go into hospital, I'll say things like, just please don't put anything on my face until I'm asleep, because then I won't know it's there and I won't feel the claustrophobia and I won't be anxious. Talk to me until I go to sleep. All of those things have helped along the way. But as I said, for the first time, going into surgery last year as a 31-year-old, and I said to my husband, you know, this is the first time I've ever gone into surgery on my own. And it felt really silly to say that. But on the other hand, I was incredibly proud that I had come this far despite everything that had happened. I know that I'm not the only one who's experienced this kind of trauma. A recent anthology entitled Growing Up Disabled in Australia has been released, and it's 47 stories written by people with lived experience of disability. Not parents, not carers, because those aren't lived experience of disability. While important, they are observed experience of disability. These 47 people all have incredibly different stories. Why wouldn't they? We're not a homogenous group. But one thing that stuck out to me in reading this anthology was that we all had some form of experience with trauma. And a lot of it had to do with medicine. If not for the way that we were treated or spoken to or not spoken to, then an experience of viewing disability from the medical model, that is, needing to be fixed or cured. Some of us in the disability community don't want to be fixed. We don't feel that way about our disability. We're incredibly proud and see it as part of who we are. And I know it's really difficult for some people to understand that, because why do you go into medicine? You go into medicine to make things better. And I think sometimes you need to understand that everyone's life can be seen in such a different way. And it's all about how we frame disability. So in my role as Disability Affairs reporter, in the last year, I have covered some incredibly tragic stories. Stories of women having a pregnancy scan and being told and given information to have an abortion once a diagnosis of Down syndrome for an unborn child is discovered. Not encouraged, not given just information to make their own decision, told it's what you should do. I've also covered stories where autistic women have struggled with mental health their entire life. They're more susceptible to eating disorders, anxiety, and depression. And yet when they go into a doctor's surgery, they're made to sit in a noisy, overstimulating waiting room. How can they be blamed for having meltdowns when they are in sensory overload? They often walk into a surgery and find that it's hard to understand multiple parts to a question. There might be 3 parts to a question that a doctor's asking. And autistic people need more time to process. And so while you're on the 2nd or 3rd part of that question as a doctor, an autistic person might still be thinking and considering and listening and taking in the first part of your question. And they'll miss the 2nd and 3rd part. And autistic women have told me that that's rarely understood or taken into consideration. Autistic women in this particular story also told me that for them, knowing who they're going to see, the environment they're going to, is it going to be the same? Is it going to be the same doctor? It takes an incredible amount of processing time and energy to get used to an environment or to people and to the kinds of language that's going to be used in an appointment. When that all changes all of a sudden, that person finds it hard to therefore understand who they're seeing, why they're seeing them, and it makes it really difficult to go ahead with an appointment. I've also covered other stories relating to COVID-19, of course. And one of them in particular has been the use of telehealth. Now, people with disability have been crying out for telehealth for decades. I spoke to one woman who hasn't left the house or her bed in 20 years because of chronic illness. And she was absolutely delighted when telehealth was accessible for her, but so terrified at the same time that when COVID ends, whenever that might be, that it will just be taken away. For some people, telehealth, like me, for example, has meant that it's so much easier to get to an appointment. I don't have to rely on my husband or expensive transport to get there. I can just do it from the comfort of my own home. But for others, for example, in the autistic community, it's been a struggle. I did a story on women who were unable to continue with psychology appointments because they simply couldn't tell the difference between home life and the psychology appointment, because all of a sudden that psychology appointment had entered their living room. I guess I want to say that I'm not sharing these stories to put anyone in a naughty corner or to make anyone feel bad. I'm also incredibly supportive and grateful to the medical profession, and have been, and wholeheartedly believe in everything that you do. But I think what I want to really get across is that everyone is unique. We all have very individual needs, and we should be treated in that way. We're individuals that all have a very unique perspective, and you should include us in our own care and not just talk to our carers and family members. And if we don't communicate in non-traditional ways, if we're non-verbal, if we don't communicate through written or spoken language, find a way to communicate with us. There is always a way. Thank you very much for having me here today. It's an absolute pleasure to come and share some of my personal and professional experience with you. And I look forward to, hearing some of the words you've come up with and also some of the questions that you might have around healthcare. I really support and believe in everything you do, and this session is really about helping you all become better practitioners so that you can serve people living with disability. There are 4.4 million of us in Australia. If you don't cater your services to suit us, that's 20%. I think so. I think it's 20%. My maths isn't good. 20% of the population that you are underserving, and that's a travesty. Thank you very much, and I look forward to continuing the conversation.
Thanks so much, Naz, for sharing those stories, your own and others, and your reporting on the Disability Royal Commission is going to give us so much to think about. I think you were talking about communication needing to be accessible in healthcare. Communication in general about health issues needs to be accessible to everyone in the media, and we're going to introduce ourselves in just a second. But I think the lack of representation of disabled people having lives and not only being inspirational stories or someone to pity with a terrible thing going on, that's a big part of perhaps why, as health professionals, we are not prompted to think about people's access needs. So really, this session is not at all supposed to be an us versus you or us versus them situation. It's just talking about how we can make sure that we actually remember that people have different needs, so then we provide great healthcare. But if you haven't yet, just add your words in, and we want to bring up the word cloud and start to have a look at what disability looks like from our kind of gut feelings. Challenging, I love that. I'm not going to read them all out, but we're going to each introduce ourselves briefly, and then we'll get into talking about the main things that we think of when we think about disability with regards to our healthcare access. So I'm Gillian, as I said before. For blind and visually impaired people, I am a tall, thin white woman. I'm wearing a colourful skirt and pink shoes, which are my personal favourites. I am a physiotherapist who works in rehabilitation research. My pronouns are she and her. I'm queer. I'm a mum. And I think they're all the kind of important things about my identity, as well as being disabled. Jean-Frederick.
Thank you, Gillian. My name is Jean-Frederick Levesque. I would like to say I look like David Bowie, but unfortunately, I know my kids will probably say I'm a middle-aged man and probably a bit nerdy. So I wear thick-rimmed glasses, and I'm not really tall. Professionally, I'm the chief executive of the Agency for Clinical Innovation. I'm a medical doctor by training, and my clinical practice was mostly with refugee claimants in Canada, where I'm from. And I've been in Australia now for 8 years, previously leading the Bureau of Health Information. So I do have some professional experience that relates to the topic of the session today.
Thank you. And Jono.
Cool. Hi, guys. I'm Jono. I'm a thin Asian guy. I'm wearing a black coat shirt and some creamy pants. My wheelchair is nice and black, but my front wheels, if you haven't noticed, actually sparkle. So it's like wearing those little kids wearing those shoes when they walk and they sparkle. And sometimes in the shopping centers, we sort of eyeball each other and have that look. So quite cool. I'm a PGY1 intern at Royal Prince Alfred Hospital. on my medical term at the moment. I'm in renal transplant, so like a super generalistic, easy term to begin with. But med school wasn't always that easy. I broke my neck about 9 years ago from a trampoline accident. At that time, I was trying to qualify for the national team, and I broke C5 and 6. So, as you know, with the spinal cord injury, there's lots of things that go on, and sort of lack of movement is just one thing. So, there's spasticity, there's bowel and bladder dysfunction, there's autonomic dysfunction. So I'm no different. But I'm very, very glad to be here today with you because it means I don't have to round the boss this morning.
Awesome. And Naz is also part of this panel discussion. So when you're thinking of questions to put to us on Twitter, include Roger, then yeah, you can direct them to any one of us or just in general. So my main thing, if I was going to have one word that I think of when I think of disability, I think I just press pause rather than progress slide. Good on me. Can someone progress the slide for me because I have not worked out how to do it myself?
Try this
so, yeah, try that one. Anyway, hang on. Anyway, that wasn't going to be the first slide, but it can be now. So these are all the different parts of me. So, yes, I am sick. I've got a peripheral neuropathy, which is an autoimmune cause. It's chronic inflammatory demyelinating polyneuropathy. And also I have Ehlers-Danlos syndrome. So the disabilities that I have are mostly invisible, but there's motor sensory problems, there's autonomic dysfunction, bowel and bladder problems, and I spend a lot of time having infusions, and I'll get into kind of how my experience in the healthcare system throws up access barriers a lot. I also, I'm a mum. So in managing all of these things, my word is busy. Like I'm really, really busy, and not to, go, we like to talk about how busy we are because I think that's kind of some way of valuing ourselves as productive. But my busyness related to healthcare appointments is a massive barrier for me actually having enough time left to work. So what I decided to do with all my free time a little while ago was do a diary review of 9 years of my life, and I had a look at, split up the waking hours. So 8 hours in a 24-hour period is gone for sleep. This is a representation of, and on the screen it's like a donut chart. It's a representation of all of the waking time that's left. So my health appointments take 15% of my waking time, averaged out across a year on a diary review. So that's a real lot of time. Then for the chronic condition self-management stuff that I'm supposed to do to manage my health, anything extra than what anyone would reasonably expect, if they didn't have a chronic illness or a disability, that takes an extra 10% of my time. 30% of my time's in work if I'm working full time, and that leaves 45% of my waking hours to do other stuff. So that's 3.7 hours a day, averaged out across a year. Like, yes, some of that time might be I'm in surgery, I'm in hospital for 3 or 4 days at a time, but across the year, 3.7 hours per day is needed for me to manage my healthcare, attend health appointments, including travel. And that's my experience, but that's actually backed up in other research looking at chronic condition management. You're nodding furiously, Jono, going like, yeah, it takes all of this time to do health management stuff. So just in the last year, in 2020, I saved 46 hours in travel because some of my health appointments were offered via telehealth. So that's a lot of time where I can earn money and not lose my job from not needing to take all. That was just the travel hours. So telehealth is not the solution to everything, but every time you're thinking about, should I offer a person a choice of face-to-face or telehealth, whether or not they look like they're from a rural place or they look like they're a person who physically will have more difficulty accessing the service, like just offer it to someone if you can. And if you're designing health services, I think I want you to take home the thought or kind of reflect on how convenience can actually be an access and inclusion issue. So if I cannot work within the health system because I'm always at health appointments, then I can't earn money, and we know that not having money leads to bad health outcomes. That's my kind of introduction to there. Have we got any comments or questions about healthcare system logistics or convenience?
So we haven't got any questions on convenience as such as yet.
Then perhaps I might, because you were nodding so furiously, do you want to add anything talking about just logistics of healthcare and like the value of our time?
I think I'd fully reflect on some of those things you said in the past. Going to health appointments, but actually seeing the doctor is only a minute part of the whole experience. I think as health professionals, we only see people when they're there in front of us. And a lot of times you don't think about the things behind that. So, for example, the actually taking time off work to get to the appointment. Then you might need to drive. Then you might have to sit in the waiting room, sort of thing. And then there's also going back. So you're leaving, you're going to the car park. You're trying to arrange your day around this whole appointment. So I totally agree. It's definitely a lot of work, and it's a lot of commitment to looking after yourself.
Yeah, and like Naz, have you had the option given to you about how to actually, whether or not you should have a telehealth or a face-to-face appointment?
And recently my GP, when I called to make an appointment, said, oh, love, you've been here 2 times this week. Why don't you just have a phone interview and a phone appointment? And I was like, well, I didn't know I could have a phone appointment. And so you just book it in, and it was amazing to be able to do that. And I thought, why haven't I been doing this for 30 years? When, obviously there are some things that you absolutely need to go and see someone face to face, but a phone or telehealth appointment, that's the journo in me, appointment is just so convenient, and it means that I don't have to have that sort of stress of relying on other people to get me there. Either paying a lot of money for taxis or relying on someone to have the time to take me, or getting public transport.
So, I mean, we're hoping that choice, and I think you're going to touch on this a bit later, Jean-Frederick, choice is really important, but not just kind of as a nice touchy-feely thing so the person feels like they were listened to. Like, it leads to actual health outcomes and your ability to be employed and things like that. I mean, I went over and above with, like, going for my access needs. I was in a relationship with the telehealth manager for my local health district for 4 years. And even then, not to get telehealth appointments, but even then, knowing all the insider stuff that I did, I still had to have these arguments with administrators and reception desks about when they'd say, oh no, telehealth isn't available to you because you only live half an hour from the hospital. And I'm like, I know it's available to me. I know how the billing works. I know this. And still, it's always... And this kind of relates back to the trauma. You're always put in a situation where you're having to justify what your needs are when you're actually only asking for something possibly that exists and it's available and it's an option that you knew you had. And then I've been kind of berated loudly in waiting rooms by people saying, but you don't live rurally, that's not for you. And anyway.
I think it's not only based on your location of where you live, it's also... in the past, I know that people who have invisible disabilities, for example, have asked for some accommodations to be made, and they almost have to fight to prove that they require that adjustment, and often they're made to feel bad about it, and I think that's something that can often get in the way as well.
Yeah, absolutely.
Yeah. I think basically what we're trying to tell you is that having a disability requires a lot of time. And when you're thinking of planning to do, whether it's appointments, whether it's procedures, that there's lots of things in the background that you can't see. And I think that's why when I do talk more about my area, it's about understanding the lived experience. And while not everyone needs to have a lived experience to be an effective clinician, listening to more stories and being involved in that aspect can actually deliver better patient outcomes.
It's probably, and because you're going to add to this, so I realise that we've ignored you so far. But Jono, do you want to just bring up the word that you've thought of as the kind of a really important word for you when thinking about disability?
Yeah, so I mean...
So if we could just put Jono's slide up.
Yeah, so when I did this exercise, the word I came up with was actually workforce. And this isn't about having quotas or anything, but actually thinking about people with lived experience or disabilities in the healthcare workforce. We know diversity is such an important part. We know that, for example, having gender diversity improves patient outcomes. You reduce error, you reduce length of stay. And that's been shown that, places that have better gender diversity actually have better outcomes. So it's a no-brainer to say that if you have a more diverse workforce, it can be better for everyone. So I want to share a little story about about when I first started up here, that sort of highlight some of the inequities that sort of I faced. So when you first start in a new term, you have to arrange your med term, your surge term, ED relief sort of thing. And so I went to my JMO manager, and we had a chat. What was the most easiest thing, and what was the most how were we going to arrange the year to be successful? And it was a really good conversation, and I got home and really looking forward to this year. And about a week later, I got a phone call from her and saying, "Oh, look, there's some problem." And I was like, my first thought was, "Oh, what? So you couldn't roster me for like 5 orthopedic terms?" But no. All seriousness, what happened was, in arranging my surge term, one of the head surgeons there heard about me. So there's this new intern starting at PA, and he's in a wheelchair. And basically what he said was, no. He said, no, he's not allowed in theatres to scrub or assist. Just black and white. And initially I was a little bit taken back. I was like, oh, yeah, okay, that's not quite right. But look, wasn't a surprise to me. Maybe he just didn't understand who I was, sort of what I did, sort of thing. So, some of the strategies which I came up with, or maybe I'll talk to some of the bosses at North Shore where I was as a student, like how do we overcome some of these problems? And we had a discussion, and maybe he just didn't know how I scrubbed or how I assisted. I mean, at North Shore, I helped with cesareans, I assisted, I was holding retractors, the worst thing ever, but help close, and we came up with a few strategies, how to approach it. So when I spoke to the bosses there, their first reaction was outrage. They were outraged that this was even an issue. And the reason it was an issue, it wasn't like they were outraged, is because, I went through the same medical training as all my peers, and it was only because I'm in a wheelchair that I had to prove myself. And so I was a little bit surprised too, because I've never really thought too much about myself. But it goes to show that, maybe because I'm so used to casual discrimination, and a lot of people with a disability are so used to being discriminated against, that it didn't even register with me. So it goes to show that people with disabilities face lots of barriers, but the biggest barrier is actually attitudes and beliefs. And so one of my points I wanted to take out of the story was, I wanted to challenge the audience that, if ever you have a colleague that comes across with a disability, don't be afraid to ask. Don't be afraid to know a little bit more, because challenging the normal perception of disability is what we need. We need to normalize it and not make assumptions or not assume, but actually understand what people's abilities are and what limitation they may require. And touching on what Naz was saying, I'm actually quite fortunate because my disability, I stand out. I'm in a wheelchair. People feel sorry for me. But a lot of people with disabilities are invisible. So whether it's a mental health, vision, hearing, whether it's a behavioral, they fight really hard for the support they need. So if we want to look after our patients, we've got to first look after ourselves.
Yeah. If I could add 2 things to what Jonathan has said. Firstly, people with disability are so used to discrimination. It's terrible, it's sad, but it's fact. We are so used to it. And I think there's nothing casual about it. quite frankly. Discrimination is discrimination. And so that's the first point I'd like to make. But the second is that research overwhelmingly shows that people with disability are just as hardworking, just as productive, take less sick days, and because of the nature of the barriers that we face because of society, because of the environments around us, we are incredibly resourceful and adaptable. And so we are constantly thinking of ways to get around whatever it is, whatever attitude you have or poor access to a building. We are constantly innovating and thinking before anyone else is about how we will navigate something. It shouldn't be on us to do that, but that's the reality, unfortunately, that we're faced with.
Yeah. And you're also, Jean-Frederick, working on digital health strategy and implementation. You've been thinking about workforce and how to support, access for staff through these things. Do you want to comment more on that?
Yes, thank you. When we think about virtual care, we often jump to the conclusion that this is just for patients. But the reality is that a lot of clinicians live and work with disabilities themselves. And virtual care needs to be something that becomes a tool for clinical practices as well. It's really a technology that can help that interaction to be completely different in terms of clinical delivery. And I will talk a bit about it because there were two ideas or innovations that I wanted to bring to the table. But if I may share my word, my word was not really original. Because of the title of the session, it's accessibility. But I still wanted accessibility to be my word because, first, I was born in a very remote, isolated community in Canada. And any problems for family members, including some of my family members with disabilities, were, the biggest problem was access to healthcare. Having to drive 12 hours to reach a center where there would be a specialist to see the specialist for sometimes 10 minutes and then have to drive back is not a great experience. And then professionally, working with refugees and also some experience that I've had in South India where I did my study, accessibility really has, then got to my professional life and has become a focus for me. And what I want to share now, yeah, you can see the slide. Really, my first point is that we need to consider access as a journey for anyone. And that journey, when we think about access, very often we just think about the clinical side of things, the opening hours, the cost of care, the types of treatment that you may be able to find in the practice. Previous slide, please. But the reality is access is determined by everyone's ability through that healthcare seeking process.
So I just want to point out the word on the slide is ability to, and we had like a lovely argument about this actually, just in our preparation session, because it's not about getting rid of the dis or anything naff like that and just seeing the ability, but in terms of access requirements and access needs, people actually need to have the ability to engage, like you're saying.
Absolutely, and every patient faces, they're facing many hurdles to actually obtain what's really relevant for them. It's about the ability to perceive your problem and think that you can be helped by the system. It's about the ability to seek healthcare, and we know that many groups will be discriminated, not being able to seek healthcare right from the start. Reaching physically is obviously a hurdle for many people. Ability to pay can be a big problem. And then even when patients are in the practice with us, the ability to engage we cannot take for granted. Some people will have more difficulties to express what they truly need. So we need new tools to to make sure that clinicians can actually bridge those abilities and disabilities that people have across the entire journey so that they really truly receive what's needed. It's not just the patient's responsibility. The system has to adapt to those different abilities and the challenges that it poses for patients.
It's always made me just absolutely astounded that healthcare seems to be kind of one of the last frontiers in being more inclusive for people with health problems. Like I've been able to ask for, here are my access needs in other things, in other industry, the ABC's advertising looking for disabled talent because, it's not just nice, but Naz has touched on some of the advantages for employing disabled people. And in healthcare, it's like, you don't know where you can actually ask anyone for your access needs when you make an appointment. But I'll shut up again and show you your next slide.
Your point is very true, and there's a cultural element to it that we all need to work on to create that change. But there's two things I wanted to discuss more specifically, and there are things that we're really trying to do in New South Wales to improve access to healthcare and the appropriateness of care for people with disability, as well as the entire population. And the first one, of course, is virtual health. And we're really trying to accelerate virtual care during COVID-19, but also we've been working on many different tools that would help virtual care not just be a technological add-on, to clinical practice, because that's not really going to work. Having an outpatient clinic where some patients may come virtually and some patients may come face-to-face actually requires to have a different way to manage appointments, manage receptions, welcoming patients, the coordination with, lab tests and all of those things. So we need to think about virtual care as a redesign process. It's not just the technology, it's about redesigning the models of care, the way we work as multidisciplinary teams. And to do that well, we'll need to engage patients with lived experience, so that we, again, don't assume that with virtual care technologies, as clinicians, we know what's going to be the right solution to the problems that people are facing to access healthcare. So it's really going to be a journey where clinicians and patients need to come together, look at the available technologies, and then reinvent the way we deliver healthcare. The second idea, that's the next slide, is the idea of patient-reported measures. And it's either patient-reported experience, which is really about the way patients feel about their healthcare. Do they have continuity of care? Do they have to repeat themselves all the time when they come to see us? Do they feel respected? But it's also about outcomes, and I want to emphasize a bit more that point. Very often when we treat people with disabilities, we will look at the disability as being the main reason for complaint right from the start. It's the default setting. The reality is that people living with disabilities have various health problems or aspects of their health that they would like to be considered as part of their care. And what we're doing with patient-reported outcome measures as a program, and we are currently rolling out in New South Wales a system that enables patients before their appointment to reflect on various aspects of their quality of life. Do they feel a bit depressed today, or do they have more difficulty to move around compared to usual? What we want to do is for clinicians to have that information at hand when they're in the consultation room or on the ward with patients. And then they'll be able to, yes, address the diabetes or the specific health condition that from their own specialties clinicians come to the appointment with, but also have a broader view of the whole person and their needs. Because the reality is, even when we think about very visible problems or very specific health problems, we may find out that very often it's other aspects of quality of life that will truly make a difference for patients. And what we want to do is to really make it systematic for clinicians to access that information and be able then to engage in a conversation with patients and reflect on the current situation. How do you feel today? How can I really help you? But also reflect on progress on things. So that may prompt much better access to healthcare, because an endocrinologist may actually be able to see, okay, you're not moving very well right now according to what you're saying. Is there a way I should connect you with someone? Should we follow up with another provider that you're currently seeing, and really promote that appropriateness of care in the practice? Because too often we focus on the specific problem, and then we ignore the other things that will really make a difference.
And
so these are the two things I really wanted to emphasize today, because I really think we could do that. This is really concrete actions we could do, we could adopt in clinical practice, and that would really make a difference.
I think the important thing to note as well, that there are tools out there already to help with this. For example, a peak body that supports people, autistic people, Amaze in Victoria, has just put out a guide. And partly it's for autistic people to know the kinds of ways they can articulate what they're feeling, how they're feeling, their symptoms, either through a diary that they might keep or through storyboards or drawings or whatever it might be that suits them and their needs. But it's also for clinicians to read, to understand the types of perspectives that your patients are coming to you with. And so some of these tools are already out there and they're at your fingertips. They are there for you to use.
I think it's about focusing on what the patient wants. And touching on what Naz's story, and also, the patient-reported outcome measures. As clinicians, we tend to, we like numbers, how's the hemoglobin, is the K not too high, sort of thing. But it doesn't matter if, they've got a low hemoglobin, if they can't come into clinic because they're just too tired. The whole point of this is to understand the patient experience. And I know, working with the ACI with spinal cord injury, a lot of people out there think lack of movement is the biggest problem in spinal cord injury. Whereas if you actually ask patients, it's actually the bowel and bladder dysfunction. How can I get my bowels moving? How can I improve my bladder function? That is their main goal. So at the moment, we're trying to frame research to how to try to target these areas. But at the same level, clinicians, you have to know what is the most important thing. And maybe sometimes, they don't want to fix their movement. They actually want to fix some of these autonomic issues. So it's really important as clinicians to not just look at the numbers and actually look as a patient as a whole from a holistic sense.
Yeah. Do you have questions, Roger?
Oh my God.
Fire the questions at us. We've got a bit of time left to talk. We haven't just...
Yeah. We've been going nuts here. It's a really, really simple one, but it caused a bit of fury, is that people, Jonathan, want to know what happened with the scrubbing in. Did you get to scrub in?
Yeah, so I think basically it's a lot of massaging at the moment with different people. I think we're working on it. My search term is number 5, so we've got a bit of time. I think in the end, it's really about just people knowing who you are. For example, when I was at North Shore, all the theatre people end up knowing me. It wasn't as though I was just this... I remember one of the first time I walked in the theatre, so I buzzed in and I went in. The theatre manager, she's like, "Are you a patient?" Like... And I was like, "Oh no!" I showed him my badge, and I had to. I think it was some gynae procedures I had to go in. But it's just stuff like that. I think once people know you, then they understand what you can do, and you're not just a foreign person. People at RPA have actually been quite lovely. The culture there is quite supportive, and I think once people start knowing you, then they're really happy to help.
Yeah.
Okay. Thank you. I guess this is a question that really goes out to the entire panel, but maybe to Jean-Frederick somewhat, is the barriers to physician uptake of telehealth. Because, I think to some extent, all of us, I know when I was listening into you guys talking the other night, I was surprised at how keen you were on telehealth, because we all hate Zoom. And yet, you've given us a compelling reason for why it's really useful. And I wonder what you think the physician uptake barriers are.
Now, don't get me wrong, we love shaking the hands of our health professionals, but not at it's weighing that up between, it would be nice to see you face to face, but actually I can't waste 3 hours of my day doing the trip to that if actually all you're going to do is look at my blood work today. So too bad. I'll see you in person next time when you have to touch me. But yeah, do you want to answer the question?
Yeah, I mean, the experience, COVID has been so disruptive. But the reality is that everybody had kind of to default to a replacement solution. You know, let's all go on the telephone, or let's use Zoom to see some patients, etc. But the groundwork to make this work for clinicians as well and embed it in clinical practice needs to be done. We need triage tools to identify what are the consultations where virtual care will work and what are the types of consultations where it wouldn't. And then we can engage with patients and give a choice, but also provide the right argumentation about, you know, why a face-to-face consultation is really relevant now. The evidence in the literature is clear. You know, there's a lot of benefit of virtual care, not just in terms of the patient experience, but also in terms of clinical quality of care. There are things that work really, really well in virtual situations, and for some subgroups that have tended to be stigmatized and for whom access to healthcare may be a challenge, virtual care was providing a safe space. So we need to learn about that and work with clinicians so that it works out. But you're right to say that, you know, and we've had many clinicians come back to us to say, oh my God, this is not working because, you know, patients forget their appointments. I go on Zoom and I wait forever. I don't know, I thought my next patient was face-to-face, but not, and it's clunky at the moment. So we really need to work to, again, redesign what is an outpatient clinic so that we can really harness those technologies in a way that will fit into clinical practice. Because let's be honest, you know, every clinical encounter is a partnership between a patient and a clinician. And the patient needs to be really driving the way we design healthcare, but without ignoring how it will fit with providing good, safe clinical care. And we've got a lot of work to do. So that's why we're investing in a virtual care accelerator with eHealth in New South Wales, really working on all of the different aspects of delivering healthcare and try to revise the way we work, engaging patients in local areas to build pilots and new ways to work.
How are consumers involved in that process?
Well, there's methods for that. I'm really a science person, you know. That's why I said a bit nerdy in my
We're all
introduction.
Scientists, though, in medicine and healthcare.
So there is a lot of science around it, and there's also a lot of learning about how to use those tools. You know, co-design is a method that we can really use in many different areas. We can also really make sure that we go more broadly to a broad range of people and really try to understand what are the most common problems, etc., and then create that space where clinicians and patients can work together at designing a solution. And our role at an agency like ACI is to really be the facilitator of that process, so that, you know, when clinicians and patients agree, we move on, and when they disagree, we try to find out why, and then build something that will, you know, create a jointly owned solution. But it's a lot of work.
Yeah.
It's a lot of time. It's a lot of effort, and we need to do it in a rigorous way and in a way that is also respectful of everybody's expectations. In that, so we're learning to increasingly use these co-designs approaches in healthcare system redesign.
Yeah, and I think we can't forget that all of this rapid telehealth implementation happened in the middle of a global pandemic. Like, I've been providing telehealth appointments and receiving them, and it's been the most stressful time that most of us have ever experienced. So the experience, like, it feels almost like you can just, we hate Zoom because we want the pandemic to be over. I think there's an element of that, and people haven't had the brain space to learn and the cognitive capacity to learn all of these new ways of doing things whilst there's such, you know, high level of stress and uncertainty and everything going on for patients and clinicians. I'm going to stop there because I've got a lot to say about that, but I'm not going to. Do you have another question?
Yeah, I've got stacks of questions. There's perhaps another simple one to the group, which is, in terms of research design, how do researchers access the consumers in a way? You know, I guess that there's a bit of uncertainty as how do you go about getting people's voices?
Okay.
Yeah, so I'll answer that one because I'm actively involved in research, and that's a great question to whoever put that in, because research or co-design has to start from the top. So you have to involve people with lived experience right from your protocol. So when you're submitting ethics, you have to have consumer involved, because if you don't have that involvement at the start, then the whole design process is about what the clinician wants, not really what the consumer wants. And so,
not just about wants, right? It's like, how is this solution going to work to deliver better health outcomes?
Yeah,
and
exactly.
if you don't define what the outcome is supposed to be in consultation with the consumer or the patient or the person, then you're really just going to them to get a check. Like, do you think this problem that we've solved is going to be good?
Yeah, exactly. And so to answer the question of how to involve consumers, there are actually lots of consumer groups out there that, whether it's autism, whether it's multiple sclerosis, whether it's spinal cord injury, that do have active involvement. And so if you involve those agencies at the start, they can direct you in how to best involve lived experiences in your research.
Or employ them. So, part of my job is I work in recruitment. So I involve patients in stroke research. I look for participants and I help trialists kind of design their recruitment strategy. And in doing that, when we started this project and I was tasked with it, I really, the job description was find the participants for the trials. And just, go spend more time in hospitals and you will find them and then they will participate. And it very quickly was clear that that wasn't going to work. And where it did work, without kind of the redesign of the whole culture around this platform, where it did work was where I had existing relationships with people who live with stroke. And not just friendships, but also we need to actually just accept the skills and lived experience of people as expertise that's needed in a team. So if you're organising a project, you need to make sure that you involve people with the relevant expertise, and that includes lived experience, it includes clinical experience, it includes health manager experience, depending on what the project is. So I think you kind of also just need to know people and have relationships with people. And if you work with people with lived experience that's relevant, that's way easier, because at least you've got a starting point and you get to know about the things that are, this kind of culture stuff around disability. Disability culture is something that I didn't even really know existed. But yeah, I think employ us and then seek out members of research teams that are going to have the expertise that you need. Were you going to add something?
Oh, I just agree with you. I think that there's so much knowledge that we can learn from patient experience, clinicians' knowledge, and the new technologies of virtual care, but also telecommunication, etc., are really helping many research projects to have that added component to it. There's lots of virtual care trials going on at the moment. It's a world of possibility.
But we probably could run a workshop on consumer involvement in medical research. And to me, I've run workshops in this space, but the most important things are kind of breaking down the power structures when you're working within a research team. And most of us are used to having a patient doctor or a patient-clinician relationship with consumers. And that doesn't work if you're working together with someone as part of a project team. So kind of your approach to working with people needs to be different there.
And not be afraid to engage, because just because someone has lived experience doesn't mean they may have other experiences too. So they may be a researcher or they may be they work in other fields. The importance of involving lived experience is that you can design a trial that will actually fit with the lives of the people you're trying to investigate. So a great example here is in spinal cord injury. If you're going to make appointments for whatever reason, don't schedule it in the morning when they're doing their morning routine, because it takes a while for them to get up. So, just simple things like that can, if you have consumer input, that makes it so much easier for you to design a successful trial and have the patient numbers to be significant.
If I can share an example, I recently did a story about how people with disability are really dominating the tech space at the moment. There are so many startups and accelerator programs where people with disability are at the forefront of creating assistive technology, and traditionally that assistive technology has been designed, manufactured by non-disabled people for many, many years. And it now is this really big, exciting thing that people with disability are designing our own technology, but you sort of stop and wonder, why wasn't that happening the whole time? If you're non-disabled and you're designing technology that you don't even necessarily need to use. How do you know what we need? That's the best way to sort of look at it, I think.
Yeah. Roger.
Still going? Wow. So exciting. I guess there's a couple other questions that have identified the sort of gap or accessibility to diagnoses, particularly for chronic health conditions. So I think it's, maybe particularly relevant in the paediatric world, where there's a couple of people saying, what can we do to address that accessibility where you often have to wait months for sort of chronic healthcare appointments and things too?
So specifically, the question is about how do we
narrow the gap and make the sort of diagnosis and seeing clinical help faster, because it sounds like there's a lag in often in establishing diagnoses and things because people have to wait months for appointments.
Okay.
Well, I can just re-emphasize the two areas of work that I talked about today. If we have a more routine assessment of people's quality of life as part of clinical consultation, we will unearth problems earlier for patients, and that will support early diagnosis. And virtual care is not just for that, clinician-patient interaction. There's a lot of clinician-to-clinician interactions that can be harnessed through virtual consultation and in-reach program, so that we support primary care, we support generalists working in rural areas, and increase capacity to address some of those problems despite the allocation and physical distance problems that we're facing. And another thing I would like to emphasize is that those technologies help also patients to connect together. And to a great extent, that's an area that's really evolving and developing, and we need to harness that as well. There's a lot that can be done through peer support. Not for everything, but certainly in many healthcare conditions, we need to make sure that that virtual technology is available for groups of patients that want to create that connection and that peer support.
I was reflecting on that as well. I mean, I've got a genetic connective tissue disorder, Ehlers-Danlos, and the wait for a diagnosis and the wait to see a geneticist in the first place is extraordinarily long. I got my diagnosis when I was 20, I think, and I'd had lots of problems beforehand. But many people aren't being diagnosed until they're adults, and are being kind of told just that these things are normal growing pains. But what you made me reflect on was the interesting environment that it is being in online patient support groups, and then some of the stigma that comes around that when you might bring new information to a health appointment to say, well, look, actually other people who are in this support group have said this about a treatment. And especially when someone comes to you talking about a treatment that really isn't based in any science, the way that you react to that as a clinician can actually cause some access barriers for people. If you react and think, oh, what have those unskilled people been telling you in your group, that's not going to work, and you're not open to understanding all of the knowledge that patients have together about what it actually is like to live with the condition, like that's a big problem. And perhaps people, because they are waiting so long to receive medical care and diagnoses, they're turning online. Of course, of course we are.
Absolutely.
I think another thing that I would point out is the importance of early intervention as well. I mean, I have a secondary condition. We don't rank these things, but apart from my vision impairment, I also have a neurological condition which affects my ability to read Braille. I have a lack of sensitivity in my fingertips. Now, I struggled to read Braille for basically my entire primary school education. I was falling behind incredibly quickly, and I had this support teacher who kept saying to my parents, no, she's just really lazy. She just needs to keep practicing. Don't make excuses for her. She needs to just go home every night and she just needs to read and read and read. And it wasn't until I was about 9 or 10 years of age where I was actually taken to a neurologist and diagnosed with the condition. And it was actually really exciting because I finally had this reason for why something wasn't working the way everyone perceived it should. But also it meant that we could come up with new strategies. And that could have happened so much quicker, I think, if I was listened to and if there was a bit more sort of monitoring and evaluation. And there's a lot of research around this particular condition that I have now, but at the time there really wasn't. It was quite new. There wasn't a lot known about it. But I think listening to patients is obviously one. And this is all of the understanding that you guys are incredibly busy. You're trying to see huge numbers of people each day. We get all of that. But I think, for me, it was this particular teacher who didn't listen. But I think just taking that into account is really important.
Absolutely. Yeah, and actually I have a smaller subgroup of my online support group, which is 3 women who I had immunoglobulin infusions and sat in the same room as every 3 weeks for 10 years. So we know each other really well. And we do like a little 3-way huddle before any of us has a medical appointment, just to cross-check, is this a symptom or is this something I should talk to the doctor about, or can we sort this one out on our own? There's huge value in connecting people and valuing that lived experience knowledge. So whatever also makes it easier for us to come to a medical appointment really prepared so that we can efficiently get to the main problem. But look, we're going to need to just very quickly sum up. If you've put more questions on Twitter, I'm going to have a great time on the train on the way home looking through them and trying to answer them. Please kind of get in touch through socials with us because we'd love to continue this conversation. My closing word is please think of healthcare convenience as an access issue and think about how do I logistically make this easier for everyone. What's your take-home message, Jono?
So as I said before, normalising disability is something which I think we should aim to do, whether it's normalising with your patient, normalising in the workforce, because basically, as we said, 20% of Australians have some sort of disability. And so if we're excluding 1/5 of our workforce, then that's a whole lot of people that brings in a lot of skill that could otherwise give us a better healthcare outcomes. So challenge yourself. If there are some people with disability, go and have a chat to them, have a talk to them. We're not afraid. We don't get upset if you ask us about our disability.
Unless it's like awful personal questions.
Yeah, or unless, do it in an appropriate situation, obviously. But rather than assume, I think having that conversation is my take-home message.
Short take-home in 20 seconds.
I think we need to get out of our zone of comfort as clinicians and really embark on the redesign journey. We've just seen that we can do it in the last few months, and now we can structure it so that it's sustainable for the future, both in terms of virtual care and patient-reported measures, so that we provide person-centered care for people.
I love it. And Naz, you can have the last word.
Listen, learn, consider new perspectives, and know that you're not always going to get it right, but please, wherever possible, ask and just be interested in knowing more about each individual patient.
Thanks so much for having this discussion with us. Gonna hand over.
That was a amazing session to just be a part of, and thank you all so much. I think a confession to the panel is that as a conference organiser for 30-odd years, I've just never really thought about accessibility until this last few weeks, and particularly Jill, because of you and Jessica. It's really going to change the way we look at how we do business and the questions we ask, rather than waiting for people to tell us they've got an accessibility issue. We'll be asking, how can we help? How can we make ourselves more accessible? So on that note, thank you all. Amazing panel. We're just going to...